Oh, great stuff. Let's understand, what is the Independent Community Pharmacy Association? What's it all about? You are the CEO. I'm hoping you're going to say we try to control pricing being one of the issues.
Absolutely no. So we're an association of independently owned community pharmacies. So we've got about 1,200 pharmacies across South Africa in all of the provinces. And basically, we advocate for good or quality pharmaceutical care for everybody. And that's why when you spoke to me about the topic we're going to talk about today, I said absolutely, because this is something we advocate for, is better therapeutic outcomes for patients.
Okay, when you talk independent community of pharmacies, um, I suppose you are ruling out the clicks and the diskems of the world. You're talking about, your individual people that own and run their own pharmacy stores. Okay,
Correct.
so that kind
Correct.
of makes sense. What sort of interest do you look after? And I know, it was a very tongue-in-cheek remark I made about price control, because we do know that's governed by SAPRA. But what sort of oversight do you do with the independent pharmacy community?
So as you rightly indicated, we have got open ownership of pharmacy here in South Africa, and we've got large corporate pharmacies. So you can imagine your small pharmacist-owned pharmacy really struggles to negotiate better prices, to negotiate with funders such as the medical schemes, and to run campaigns, public health awareness campaigns. So the ICPA was brought about to be the voice for the independent, the community-based pharmacies here in South Africa.
And I presume you are making a difference.
I like to think so, yes. I think pharmacy is an underutilized healthcare professional. And so we do a lot of advocacy work. And you know the saying, when the tide comes in, all the ships rise. So a lot of the work we do is for pharmacy in general, and in particular for the patient.
Good on you. Long may you survive to do this amazing work. And the matter at hand, quite a serious issue. And you are calling, or your organization's calling, in a petition for urgent action to improve diabetes care for children in South Africa. Now, that is a very, very serious matter. Not only, well, when we look at children, very close to our hearts, obviously, and we know what the problems are facing adults with diabetes 1 and 2. People might argue it's a lifestyle issue, but you will explain to us the two different types of diabetes 1 and 2. Some people are born with diabetes, others it's because they've made all of the wrong choices as far as um, their healthcare concerns, matter. So, and then I want to also throw something else into this very long winded question of mine. There's also been quite an uproar recently about an injectable, Ozempic, I think it is. I'm not quite sure, I can't remember the name. And I think the furore around it had to do with the fact that it is expensive to buy, but a lot of people are misusing it. A lot of people are using it to lose weight. And that is putting the actual diabetic community at risk, because there may not be enough stocks for them for genuine use to control their diabetes. So there you go, with a very long-winded question. Please, let's hear your comments on all of that.
All right, so let me, yes, unravel that question, which I could talk about all day for. So I think first of all, let's just talk about the difference between type 1 and type 2 diabetes. So type 2 diabetes used to be called maturity onset diabetes because it was generally seen in older patients. It very often is related to lifestyle, exactly what you're saying. So overweight, no exercise, too much sugar. And that was the typical profile. As our nation, we tend to be an overweight nation, and more we're seeing children that are obese. And so they changed the name to type 2 rather than maturity onset, because we are seeing this in children now, teenagers. Now, it would be type 2 that you would treat. You could use Ozempic as one of the treatment options. So type 2 is where you've got insulin resistance. You have been eating too much sugar for too long. You also have a genetic profile which predisposes you to diabetes. And your pancreas starts getting tired. You are spewing out huge amounts of insulin, and it's just not really working anymore. So here, very often the treatment is oral. But more and more we are adding things like insulin to this, and the new GLP-1 analogs like Ozempic, semaglutide, are a breakthrough in treatment, because not only does it stabilize blood sugar levels, but it also helps patients lose weight. So your obese type 2 diabetic on Ozempic gets to control their blood sugar levels. Their appetite is suppressed, and they lose considerable amounts of weight. Now, of course, we all know everybody likes to look absolutely fantastic in their bikini or their cozy. They want to be able to eat everything that they want to eat, but still look fantastic. And it started with a lot of the film stars using Ozempic for this reason, which is not where it should be used. But I think the topic we want to talk about today is diabetes in children. And this tends to be type 1 diabetes. So in type 1 diabetes, your body does not produce any insulin. So without some sort of intervention, you will die. It's as simple as that. You cannot survive with type 1 diabetes without medication. You cannot use anything orally. You have to have injected insulin. So they could use Ozempic, but that is going to be just for weight loss. The standard treatment for type 1 diabetes is insulin. And what you're trying to do is, in our bodies, the pancreas releases insulin as our blood sugar levels go up and down. And somehow you have to mimic that. And the only way to really find out what your blood sugar levels are used to be a finger prick. And I know parents that are pricking their children's fingers up to 10, 12 times a day, because your blood sugar levels vary. If you've just played a game of rugby, if you just had a cook sister, if you slept for 2 hours and missed a meal, these all affect your blood sugar levels. And the danger here is not so much the high blood sugar levels, it's the lows. So a hypoglycemic attack can go into a coma and death. And hence parents have to be incredibly vigilant to make sure that their children's blood sugar levels are monitored. Now you can imagine a child, and often children are diagnosed with type 1 at a young age, 2, 3, 4 years of age. You're now pricking their fingers anywhere from 6 to 12 times a day. You're sticking needles in them, you're injecting them with insulin. And that's when you as a parent still have control. What happens when you get to your teenagers that have to go to school, that don't want people to know that they've got a condition? I find children with these chronic conditions, be it diabetes, epilepsy, asthma, they are embarrassed. There's a stigma attached to it. There's something wrong with them. They're different. That's what they feel. I mean, it's not. There's nothing wrong with them. And it's, I don't want to say it's normal, but it is a normal condition for them. They are living with a condition. And this is where we often run into problems, are our type 1 diabetics that are teenagers. And this is why this petition, which calls for continuous glucose monitoring, or CGM, is such an important thing, and it should be available to everyone. What this is instead of pricking your fingers 10, 12 times a day, It's a little device about the size of a 1 Rand coin that goes onto the back of the arm. It is replaced every 14 to 15 days, and it continuously measures your blood sugar levels, and it feeds that information into a smartphone. Now, that smartphone could be controlled by a parent, or it could be to the teenager's phone. This means at the look at the phone, they know exactly what their blood sugar is doing. Can they have that piece of cake? No, they can't. Their blood sugar is too high. Should they take some insulin? Yes, they need to have insulin. And really, one of the reasons CGM has not been used today is around cost. And you were talking about cost earlier. But what cost can you attach to keeping a child healthy and alive, giving parents the peace of mind that the child knows what their blood sugars levels are, and giving the child the confidence to live a normal life, because they can live a normal life if they know how to treat it properly. And
okay, Jackie, a very important question here. You refer to this little device, you refer to it as a CTM. I'll ask you to give us a little more detail. What is it? Is it implanted under the skin, or is it something, just attached? How does it work? Number one. Number two, what about medical aid? If you're one of the fortunate people who are able to afford medical aid, do they cover it? You talk about costs. Could you give us an approximate costing so that people are aware of how much they're going to have to lay out for, the health and wellness of their child?
Yeah, 100%. And really, it is life-changing for any parent that can get this for their child. So you're looking at probably a couple of R1,000 a month, which, yes, I mean, if you take, you said earlier that we're sitting with an unemployment rate of 30 to 40%. For a lot of people, that is unaffordable. There are a number of medical schemes that will now cover it with motivation, specifically type 1 and children over 4. So the device is as I say, it's a very small device with a plaster. It has little electrodes, so tiny little, almost like hair-like probes that go into the skin. You apply it once, it is practically painless. I've seen it used on very small children. You apply it once on the back of the arm, so it's under a shirt sleeve, and that's it. You change it every 2 weeks. Sometimes, if it's a teenager playing rugby, it might get dislodged, but on the whole, you're looking at replacing it twice a week. Now, if we look at finger pricks,
Sorry.
Yes.
How often do you replace it? At what cost?
So the R2,000 is for a month's supply. That's for 2 sensors. It's a sensor that you apply. So it's not under the skin. The little probes actually go into the skin, but as I say, it is practically painless, the application. And once it's on, you don't feel it at all.
Okay, let's go for an ad break, and we will be back with you in a minute or two. So many more questions for you regarding this issue. We do need to know how the petition came about, and what prompted the launch of it, and recent events that highlighted the need for this very urgent action. But all of that and much, much more right after the ad break.
This Ramadan, the Islamic Dawah movement will provide meals to thousands of Muslims from disadvantaged areas, as it has been doing for over 20 years, but they need your help. A donation of 30 Rand provides an iftar meal for a fasting person. Become an IDM sponsor and earn Sadaqah Jariyah. Zakat, Fitra, Kafara, and Fidya contributions are all welcome. Call IDM on 031 304 6883 or visit idmsa.org to donate. IDM, taking Islam to as many hearts and homes as possible.
When the perfect blend of stylish decor, exquisite halal cuisine, and warm hospitality come together, it could only mean Al Bayt Lodge, your true home away from home. Al Bayt is the ideal heaven for families, business people, and tourists, with its 4-star family rooms and other luxurious facilities, conveniently situated close to Port Elizabeth Airport, the beach, and other amenities. Your stay will be truly unforgettable, as you'll be taking home lasting memories of the warm hospitality, the serenity and tranquility that Al Bayt has to offer. For reservations, call 041 583 6415 or visit www.albaytlodge.co.za.
Imagine a world where every child feels loved, secure, and cared for. At Beit Halima Saadia Orphanage, we are not just providing a roof over their heads, we're giving orphan children a chance for a brighter future. For just 1,500 rands a month or 18,000 rands a year, you can sponsor an orphan and transform their life. Your contribution covers essentials like food, clothing, tuition, therapy, and more, ensuring they grow in a nurturing, supportive environment. Any donation is accepted as well as daily scheduled donations. EFT directly into our account. Beit Halima Saadia Orphanage, First National Bank, account number 6313-1080-078, branch code 250737, Section 18A registered. Take this step today. Contact Sister Nazarene at 083-653-5669 or email info@bhscycc.co.za.
Yasin Badat Financial Advisory. Are your financial goals feeling out of reach? Yasin Badat Financial Advisory is here to turn your aspirations into achievements. Our dedicated team, armed with a history of success, is ready to guide you through the complex nature of financial and investment planning. Whether you're a seasoned investor or new to the game, our personalized solutions cater to your unique goals and risk appetite. Trust in our commitment to transparency, integrity, and excellence. Ready to unlock a world of financial freedom? Partner with us today. Call Yasin Badat Financial Advisory at +27 33346 2071 or visit www.yasinbadat.com. Yasin Badat Financial Advisory, guiding you to financial success.
Hey, Gulam.
Yeah?
Did I return your lawnmower last month?
No, bye, you didn't.
Oh, no. Now what'll I do? I wanted to borrow it again, man.
With Rendry Jewelers, you won't have to borrow or lend because the prices are so well trimmed on all gold and diamond jewelry. Alternatively, we could remake your old jewelry into a brilliant new design. Visit Rendry Jewelers at 151 Stevens Lamini Road, Musgrave, Durban. Rendry Jewelers, the family name you can trust.
Connect and stay ahead with Salam Media. This is Salam Media, coming to you live from South Africa.
Welcome back. It's exactly 11:20 a.m. Our guest this morning on the mid-morning talk show is CEO of the Independent Community Pharmacy Association. She is Jackie Maimin, and they are calling for a petition for urgent action to improve diabetes care for children in South Africa. So the question I put to Jackie just before the ad break was obviously what prompted the launch of this petition, and were there any recent events or reports that highlighted the need for this action? Welcome back, and over to you, Jackie.
Thank you very much, Julie. So this petition was called for by Diabetes South Africa, and it is a call for the National Department of Health to give access to all children with type 1 diabetes under the age of 18. So it wasn't a petition started by us, but it was a petition very close to our hearts because we see in the private sector how people are struggling to get this continuous glucose monitoring for their children with type 1 diabetes. So we thought it was a very good campaign to pick up on. And our feeling is that if, for instance, the National Department of Health had to look at this, not only does it give confidence to the child, peace of mind to the parent, there are better outcomes, better therapeutic outcomes. The child can live a more normal life. And when we look at cost, and obviously the State Department has massive economies of scale, they would be able to negotiate these prices down. We believe that it is cost effective. And that's why we're supporting this call from Diabetes South Africa, which is an advocacy group.
So, Jackie, we're talking insulin, we're talking diabetes care. I'm trying to understand, how does access to insulin, continuous glucose monitoring, you spoke about the CTM, I believe that's the name of the device.
CGM.
CGM. Okay.
Yes.
That would be obviously life-changing for the patients, if we can refer to them as patients, but people suffering from diabetes. So you have that issue, but then also essential diabetes supplies and the comparison between the private sector and the state, obviously, the public healthcare systems. We know what the state of public healthcare systems looks like at the moment. And I kind of wonder, are these children actually, outside of private healthcare, be able to get the type of support and care that is needed?
So, yeah, you're 100% correct. You know, in the private sector, we're very fortunate. You know, if there's an emergency with my child or my grandchildren, I can phone my doctor immediately. I can see him or her today. I can rush to the emergency department. And this is not always available for patients who rely on the state system. So if you look at a type 1 diabetic, and as I've said to you, the dangers are the hypoglycemic attack. So that's the very low blood sugar. So you're at home with a small child. You've given them too much insulin. They're in a coma. You now rush, or you call for an ambulance. You rush into the emergency department. It's going to take up a bed in these already oversubscribed state facilities. Not to mention the damage. I mean, as soon as you go into a coma with low blood sugar, there's brain damage, there's organ damage. And then the transverse is high blood sugar levels, which has really dire consequences for your eyesight, your kidneys. Just about every organ in your body is affected by high blood sugar levels. So, you know, you can't keep the child fed on Coca-Cola, for instance, to try and keep the blood sugar levels up. So we're saying if a state patient is stabilized as best they can on insulin, and then given continuous glucose monitoring, access to these devices, that child is just going to be so much better cared for, much better blood sugar levels. The parents are going to know, or the child, the teenager is going to know exactly when they need insulin, how much insulin they need. And the downstream costs, we believe, will far more, will balance out the cost of the CGM upfront. And that's why we're calling for any child. And we know that our government is strong on equality, on access to healthcare. Well, here's a vulnerable population, type 1 diabetic children living with diabetes. There is not a more vulnerable population. And we believe that this will be cost effective, and it should be up there with human rights.
Jackie, are we seeing more and more children being born with diabetes? And if so, would it mean that whilst the mom was pregnant or throughout her life before she fell pregnant, her lifestyle choices were very poor, thus resulting in the child being born with diabetes? Are we seeing more and more of this? And what I've just said now, would that be one of the main factors, or the main reasons for why we're seeing children being born, more and more children being born with diabetes?
So I think we are far more aware of children living with diabetes. The diagnosing is far better. I think in the olden days, a lot of these children died, and it was just accepted that the child did not thrive and that they passed away. So I don't think it is that we are seeing a huge increase in the number of children. What we are seeing an increase in is type 2 diabetes, which is the lifestyle choices. But a mother's lifestyle choices, as far as I know, and I'm not an expert, but lifestyle choices don't impact type 1 diabetes. You can be a really healthy couple with the best lifestyle choices. You can be fit, you can be normal weight. And at 2, 3, 4 years of age, your child, who was completely normal, is suddenly diagnosed as type 1 diabetics. They are not 100% sure why this happens. There's talk that it could be some virus that attacks the pancreas. It could be an autoimmune disease. So there's not a lot of clarity on how to avoid this kind of diagnosis. But no, I don't believe that your lifestyle choices directly impact the diagnosis of type 1 diabetes. There are far more things that lifestyle choices can impact in a child, but not your type 1 diabetes.
What about a poor diet? A mom who's maybe perhaps too young or just doesn't focus enough on her child's upbringing. This might be a 3, 4-year-old child, and she doesn't monitor his or her diet. Could that eventually impact on the child as far as diabetes is concerned?
My opinion, and as I say, I'm not an expert. No, not really. There are so many other things that these poor choices can impact on. You know, if you don't make sure that your child has access to good nutrition, you can affect their IQ, their ability to learn. You can affect their bones. They could end up with osteoporosis, muscle wasting, kwashiorkor. There's so many other things. Young parents that have maybe been on drugs, that child has a very poor outset. I mean, another one, fetal alcohol syndrome, where mothers have been drinking heavily during pregnancy. Those have serious implications on a child, but not in terms of type 1 diabetes. As I indicated, we are seeing more and more children becoming obese. So these are children that drink sodas to quench thirst instead of water, that are not given the proper milk and nutrition, and they are in line for type 2 diabetes. So that's an issue. I'm not saying that lifestyle choices don't impact diabetes, but not type 1. Type 2 diabetes, most definitely. Obese children, we're seeing a huge increase in children with type 2 diabetes, and that's preventable.
And of course, it comes down to the junk food that they're being fed and is so easily available all around. Wherever you turn, there's sweets, chips, and all of that rubbish that
Yes.
Parents think that by feeding their kids all of that junk, they're expressing their love. Be
Yeah.
that as it may, Jackie, do we have enough healthcare professionals, trained healthcare professionals in the country to be dealing with pediatric diabetes and other pediatric, diseases that we're being plagued with here in South Africa?
So, Julie, if we have a look at the WHO guidelines, we have got a shortage of healthcare professionals. But actually, adding on to something you said earlier, we have got doctors, pharmacists, nurses, diabetic educators sitting at home unemployed. It is a huge concern for ICPA that there are healthcare practitioners out there that do not have jobs. In a country where healthcare is a problem, we've got the quadruple burden of disease here. We've got a growing population. We've got infectious diseases. We've got unemployment and all the things that come with unemployment, such as drug abuse, violence, crime. And we've got a population that's eating the wrong food, gaining weight, and we're getting hypertension, high cholesterol, and diabetes. And it is just unfathomable that there are doctors, pharmacists, nurses sitting at home without work because there is no budget to employ these people. So I think our first thing is to get our priorities right in this country. And if we really are serious about a universal health coverage in NHI, is making sure that our budgets are used properly, that we get these healthcare practitioners in, that we try and bring in the private sector to help the public sector and start taking care of our population.
NHI is a bad word in my vocabulary, so we won't even go there. But it's time for us to wrap up. Let's talk very quickly about, obviously, this petition and how can your independent community of pharmacies play a role, and I'm sure they have a huge role to play here in improving the care for children with diabetes.
Absolutely. So I think the first thing, Julie, if you have a child who is not thriving, and there are symptoms to look out for. So thirst, frequent urination, urinary tract infections, children that are hungry all the time but don't gain weight, or suddenly losing weight but still eating the same amount of food. These are all warning signs. And what you can do is pop along to your pharmacy with your child, have a quick blood sugar check, have a look there. If you already have the diagnosis of type 1 diabetes and you are struggling with maintaining blood glucose levels, speak to your pharmacist about these continuous glucose monitoring devices. They are life-changing. And chatting to parents who have used these, they wish they had actually put them into use far earlier. We can get doctors or specialists to motivate for it. If you're on a medical scheme, and get your child onto a CGM, they can then live a relatively normal life, better health outcomes, less hospitalization, and a confident child, and a parent at home who can, breathe a sigh of relief that they don't have to worry about their child.
Jackie, well done to you as the CEO of the Independent Community Pharmacy Association for highlighting this very, very serious matter. Good luck with the petition, and it was wonderful talking to you. Thank you indeed. God bless.
Thank you, Julie. You too. God bless. Bye-bye.
It is 11:35. It is the mid-morning show. We are moving along, and our next guest is already standing by. She's Wahida Ismail, author of a book entitled An Unforgettable Ramadan. But we'll go to her right after the ad break.